So this is the case study that took place in the hospital. A 31-year-old male went to the doctor's office within 3 weeks persistent diarrhea and abdominal pain. During his visit, he admits to seeing blood occasionally in his stool. He also has a mouth sore which comes on and off in the past 1 year. So through a physical examination, it showed a slight tenderness of the upper abdomen. And then after that, a further order was made by the doctor, which was an endoscopy with biopsy. After that, the result showed skip lesion in the small intestine walls. Background: Crohn's disease, also called regional enteritis, has a similar condition with one other disease called ulcerative colitis, which form a type of inflammatory bowel disease. Crohn's disease is a chronic disease that causes inflammation to the digestive tract. It can occur anywhere in the tract, which leads to abdominal pain, fever, diarrhea, fatigue, weight loss, malnutrition, and so on. The exact cause of Crohn's disease still remains unknown. However, diet and other stress factors are known to irritate it but do not cause the disease. Crohn's diseases may appear without notice, and it can gradually develop and worsen, leading to life-threatening complications. Complications become severe depending on the part of the digestive tract which the Crohn's disease is affected. Experts do not know why it develops, and also there is no cure for Crohn's diseases. However, treatments and therapies can help reduce the basic inflammation, ease the symptoms, avoid complication, and help keep good nutrition. A few factors that contribute to Crohn's disease may include age, hereditary or genetics, some environmental factors, and so on. This disease affects both men and women equally. It can happen at any age. However, most people are diagnosed before 30 years. According to research, between 5% and 20% of those with inflammatory bowel disease, including Crohn's disease, have a first-degree relative who also has one of the disease. Genetic factors is higher when it comes to Crohn's disease. Cases of Crohn's disease are found among all racial groups in the world. However, its highest rate has been reported in North America and Europe. Developed countries have higher rates compared to undeveloped countries. Urban cities and towns also have higher rates compared to rural areas. The Western lifestyle in these areas is to blame for the rising rate of this disease.
Antigens are chemical structures that is on the surface of a pathogen that binds to T cells and B cells antigen receptors. The body does not recognize antigens as belonging to the self. The antigens on pathogens are usually large and complex and consist of antigenic determinants, which are small regions where a receptor can bind. Lymphocytes, called T cells, are to recognize antigens by binding to receptors, but only do so when they recognize the antigen on the surface of specialized cells called antigen-presenting cells. There are two classes of antigen-presenting cell types: major histocompatibility complex, or MHC1, and MHC2. The MHC is the cluster of genes that encode antigen-presenting molecules and results in the recognition of antigen by a T cell. The different classes of MHC stimulate a response of the adaptive immune system, such as MHC class 1 cells stimulating cytotoxin T cells to be released as a defense. Antibodies are any of the group of proteins that bind specifically to antigens. They are glycoproteins composed of two types of polypeptide chains with attached carbohydrates. Antigens can act as the lymphocyte B cell receptors or can be secreted, circulate, and bind to a pathogen, labeling it for identification for other immune cells to destroy. There are 5 classes of antigens: IgM, IgG, IgA, IgE, and IgD. The antigen IgM is made of 5 4-chain structures and is the largest of the antibody molecules. IgM is usually the first antibody made during a primary immune response. It has 10 antigen binding sites which allow it to bind well to many bacterial surfaces. The antigen IgG has 2 binding sites and functions as a main blood antibody of secondary immune responses. The IgA antibody class functions as the only antibody to leave the interior of the body to protect body surfaces and has 4 binding sites. The IgE antibody is present in the lowest concentrations of blood and known as the allergy antibody. It consists of 2 binding sites. The IgD antibody class functions as a receptor for naive B cells and consists of 2 binding sites. The immune system is a complex collection of organs and cells that destroys and/or neutralizes pathogens that would otherwise cause illness or death to the human body. There are 3 phases of the immune system and consists of the barrier defense, innate immune response, and adaptive immune response. The adaptive immune response is much slower than the other defenses and consists of many lymphocytes, or white blood cells, that help control immune responses. The primary cells involved in the adaptive immune response are called B cells, T cells, plasma cells, and natural killer cells. B cells are immune cells that derive from the red bone marrow and mainly functions by producing antibodies. B cells are activated by binding to an antigen. Once they are activated, the B cells then differentiate into cells that secrete a soluble form of their surface antibodies. T cells are also immune cells that derive from the red bone marrow but mature in the thymus. Their main function is to communicate with other cells of the adaptive immune system and to destroy cells infected with intracellular pathogens. Plasma cells are B cells that differentiated in response to binding to an antigen. Plasma cells have the ability to secrete soluble antibodies. Natural killer cells are a part of the innate immune response, but has an important role in the adaptive immune response as well. It is a blood cell with cytotoxic components, which helps with killing cells. The adaptive immune response has the ability to distinguish between self-antigens and foreign antigens, thanks to the help of B cells and T cells, which have mechanisms in place to help differentiate the antigens. T cells control a multitude of immune responses directly and control B cells in some cases as well. There are many different types of T cells to help fight off foreign pathogens. These T cells are called helper T cells, cytotoxic T cells, and regulatory T cells. The helper T cells have different functions that include secreting cytokines that act to enhance other immune responses, secrete cytokines that regulate the immunological activity and development of a variety of cells, and cytokine-secreting cells that act on B cells to drive their differentiation into plasma cells and make antibodies. Cytotoxin T cells are T cells that kill target cells by inducing apoptosis, which is programmed cell death. Regulatory T cells are suppressor T cells and are important for regulating immune responses of other T cells so that the immune response will not be allowed to go uncontrolled, preventing the body from autoimmune responses. T cells control B cells by communicating with the mature B cells, but B cells are not activated until they have been exposed to a self-antigen. Once they have been exposed to a self-antigen, they wait for a signal from the helper T cells, and if they receive no signal, they undergo apoptosis. After B cells are activated, they differentiate into plasma cells, which partake in secretion of antibodies. Memory B cells are another factor and results from the expansion of activated B cells. The digestive system consists of the mouth, esophagus, stomach, small intestine, large intestine or colon, and anus. There are also supporting organs involved, including the liver, gallbladder, and pancreas. Before digestion can begin, food must first be ingested by the mouth. Once food is in the mouth, mechanical and chemical digestion can begin. Mechanical digestion involves physically breaking down the food without changing the chemical nature, and chemical digestion consists of digestive secretions breaking down complex food molecules. Foods like carbohydrates can begin breaking down in the mouth, while proteins and lipids begin digestion in the stomach and small intestine. Mechanical digestion in the mouth occurs by chewing, and chemical digestion is processed by salivary enzymes that are released from salivary glands. Once food is thoroughly chewed, it is swallowed and propelled down the esophagus into the stomach. The stomach also participates in chemical and mechanical digestion, but most of the food that is digested here is protein. Mechanical digestion in the stomach begins by what is called a mixing wave and helps mix and soften food with gastric juices, which creates chyme, also known as a mixture of partially digested food and gastric juices. Chemical digestion in the stomach is similar to the chemical breakdown that occurs in the mouth. Enzymes called pepsin is released to help break down protein, and hydrochloric acid is also released. After food contents have been digested in the stomach and mouth, the chyme then makes its way into the duodenum, which is the start of the small intestine. Most of all the digestion and practically all food absorption occurs in the small intestine. Lipid digestion can start in the mouth with the help of salivary enzymes, but they are primarily digested in the duodenum with the help of bile salts from the gallbladder and pancreatic enzymes. Once chyme passes from the stomach to the duodenum, digestion continues and absorption can begin. Chyme continues to travel further through the small intestine, the jejunum, the middle region of the small intestine, and the ileum, which is the end of the small intestine. After most of the nutrients are absorbed in the small intestine, chyme that can no longer be broken down moves into the large intestine. The small intestine wall consists of villi and microvilli that helps with absorption of nutrients, and the large intestine consists of trillions of non-pathogenic bacteria, with some linking to an increased immune response. These bacteria found in the large intestine are called the bacterial flora. A component of the large intestine bacterial cell walls, peptidoglycan, activates the release of chemicals by the epithelial cells, which then drafts immune cells. These immune cells consist of dendritic and T cells. Dendritic cells open tight junctions to evaluate for microbial antigens. The dendritic cells with antigens then travel to neighboring lymphoid follicles in the mucosa so that T cells can inspect for antigens.
Signs refer to objective, measured factors that doctors are able to measure or identify in a clinical setting. There are many visible signs of Crohn's disease that doctors would be able to pick up on when seeing a patient. Bloody stool is one observable sign of Crohn's disease. Crohn's is an autoimmune disorder. This means that the body's immune system mistakenly attacks gastrointestinal tissue, which can cause inflammation and ulcers to form within the lining of the tissue. This can eventually cause blood in the stool, especially when ulcerated gastrointestinal tissue is in the large intestine or the rectum. Another observable sign of Crohn's disease is a fever. This occurs in severe cases of Crohn's and is a direct result of the inflammatory response in the body. Severe gastrointestinal inflammation can cause the body to induce a fever. The immune system believes there is a threat, however, it is really attacking its own gastrointestinal tissue. It ends up inducing an inflammatory response and eventually a fever in order to fight the perceived threat. Another sign of Crohn's disease are fistulas, which are typically present in the anal region. Fistulas are abnormal connections between specific areas. Anal fistulas are common in Crohn's because inflammation and ulceration of gastrointestinal tissue can cause tunnels to form from an infected area to other regions. In the picture on the bottom left, we can see the formation of an anal fistula due to inflamed anal tissue, which also has the potential for abscesses to form. This can be very dangerous, especially for women who have the potential to form fistulas between their rectum and vagina. This increases the chances of serious infections within the region if they are not treated. Mouth sores are another sign of Crohn's. It is not definitively known why these mouth sores form. However, scientists think that they may be linked to either the side effects of Crohn's medications that can cause vitamin deficiencies or basic inflammation that is associated with Crohn's. In severe cases of Crohn's disease, doctors may also observe physical inflammation of the skin and eyes. This is again due to the body's autoimmune inflammatory response, which causes inflammation and swelling in physically observable areas, including the skin and eyes. Inflammation of the episclera tissue of the eye is called episcleritis. Inflammation of the skin usually occurs on the shins, ankles, and arms. Kidney stones are also sometimes observed in patients with Crohn's. This occurs because Crohn's disease reduces the body's ability to absorb fats, as well as bile salts, because patches of gastrointestinal tissue in the small and large intestine become inflamed and ulcerated. This results in a greater chance of developing kidney stones. Lastly, children who suffer from Crohn's tend to experience a delay in growth and/or sexual development. This is because their inflamed and ulcerated gastrointestinal tissues aren't able to properly absorb nutrients, resulting in persistent diarrhea, which can also cause weight loss. These factors have the potential to stunt children's growth and sexual development. The figure on the right depicts the various physical ailments, including skin and eye inflammation and kidney stones, that can occur as a result of Crohn's. Next, we'll talk about symptoms associated with Crohn's disease. Symptoms refer to subjective experiences that individuals may feel but aren't able to be definitively measured by healthcare professionals. A very common symptom of Crohn's disease is diarrhea. Diarrhea occurs because inflammation within the small and large intestines causes food to move through the digestive system more quickly than normal. Damaged tissues in the lower, small intestine also lead to less absorption of fats, water, and nutrients, which allows for watery, non-compact stool in the form of diarrhea to exit the system. Inflamed and ulcerated tissues also lead to frequent abdominal pain and cramping among patients. Lastly, fatigue is very common among Crohn's patients. This is likely due to the constant inflammation, bleeding, and ulceration of gastrointestinal tissues. This can result in a shortage of red blood cells, which would cause patients with Crohn's to tire out and fatigue very easily.
To diagnose Crohn's, 2 types of tests are done: blood tests and stool tests. The first type is a colonoscopy test, which is when the large bowel and the distal area of the small bowel is examined with a thin, flexible tube with a camera at its end passing through the anus, which allows doctors to view the colon. If granulomas, which is a cluster of inflamed cells, also a sign and symptom of Crohn's is present, it may lead to diagnosed Crohn's. Examples of how that may look is shown in the pictures. A CT scan may also be used to diagnose. CT stands for computerized tomography, which is an X-ray technique that obtains detailed images of the internal body. If diagnosing Crohn's disease, the scan will look at the bowel and tissues outside of it, which may show bowel walls thickening due to inflammation, which is caused by Crohn's disease. If that is present in the scans, Crohn's disease may be diagnosed. Another scanning test that may take place is an MRI, which stands for magnetic resonance imaging. During this scan, magnetic field gradients and radio waves are used to create images of the organs. To diagnose Crohn's, a pelvic MRI may take place and is used to observe the fistula around the anal area, or an MRI enterography, which is around the small intestine, which is usually the areas doctors will look to diagnose Crohn's to see if there's any symptoms or signs in those areas. Capsule endoscopy can be used to diagnose Crohn's as well, which is a test where a capsule that has a camera installed is swallowed by the patient, and pictures of the small intestine are taken from inside and transmitted to the belt being worn by the patient. Images are then moved to be displayed on the monitor, which will then show if there's any signs of Crohn's going on inside the organs. The camera later comes out through stool. It'll show visualization of the digestive tract mucosa and can also show linear ulcers. Example of this is shown on the picture to the right. And if a capsule endoscopy shows any abnormalities, then a balloon-assisted enteroscopy is done, which is where a scope is used with an overture, allowing to be able to look into small bowel, showing areas that the endoscope may not be able to show. And a picture of how that method would be done is shown below.
Medication for Crohn's disease is generally divided into 4 categories. The first type of medication is aminosalicylates. These are thought to act on the cytokines through the use of 5-aminosalicylic acid. This treatment reduces the inflammation in the gut and is generally used for those newly diagnosed with mild symptoms. Corticosteroids, or steroids for short, are used to reduce the activity of the immune system. However, because reducing the activity of the immune system increases the likelihood of being infected with a virus or bacteria, they are reserved for those with moderate or severe symptoms of Crohn's disease and should only be used for a short period. Immunomodulars, or immunosuppressants, have very similar effects as steroids. These are used if someone has responded well to corticosteroids. Because steroids can only be used for a short period, immunomodulators are used after. Additionally, immunomodulators take up to 3 months to take an effect. Finally, biologic therapies can be used for severe cases. These target proteins produced in the gut with the goal of decreasing inflammation. They target, most commonly, a protein called tumor necrosis factor, while some target integrin immune cells. Similar to medication, there are different nutritional treatments depending on the severity of the disease in an individual patient's case. On the more mild side, monitoring nutrition is a crucial step of treatment. Although this can benefit all severities, more mild cases will benefit the most. Staying away from particular foods that personally correlate to more symptoms is a great place to start. Additionally, because diarrhea and loss of appetite are common symptoms, patients should be mindful of the types and amounts of food they consume. In general, patients respond most effectively to more bland foods and limiting spicy and high-fiber foods. For the more severe cases, doctors may recommend intermittent periods of bowel rest. These periods may be a few days to a few weeks in which the patient consumes certain high-nutrient liquids. In the most severe cases, doctors may administer nutrition through an IV or a feeding tube that is inserted directly into the stomach or small intestine. There are many different types of surgeries recommended for Crohn's disease, and they are done based on the severity of the disease. Medication and nutrition are both attempted first. However, surgery is the next step if these fail. The first 2 types of surgery are very similar, but occur at different points of the intestinal tract. A small bowel resection involves the removal of a part of the small intestine, while a subtotal colectomy involves the removal of a part of the large intestine. These both require recovery time. However, the patient can live a normal life after these surgeries. By removing the part that was causing the most severe symptoms or was affected by previous medication, the patient can experience relief in side effects. The final type of surgery is a proctocolectomy and ileostomy. This type of surgery is very extensive as it involves the removal of the entire colon and rectum. While the patient will no longer have inflammation in the large intestine, the patient will now require an ostomy pouch attached to the outside of their body to collect stool for the rest of their life. There is no cure currently known or developed for Crohn's disease. Often individuals will have to take steps with their lifestyles and treatments in order to keep the disease in remission. Those with Crohn's can live very active, healthy lives. Indeed, the life expectancy for someone with Crohn's is about the average of other Americans. Finally, clinical trials are increasing at a steady pace for Crohn's and related diseases. Thus, individuals with the disease should have hope for a greater future and can even assist in creating this future by volunteering for these trials. The most common age to be diagnosed with Crohn's disease falls in the range between 15 and 30 years. In the United States, there are about 800,000 people diagnosed with Crohn's. This is equal to about 200 out of every 100,000 Americans. Of those, men and women account for about 50% each and are no more or less likely to be affected based on sex. Those diagnosed will expect a 75% chance of having to undergo surgery for the condition at some point in their lives, with 38% of those having a reoccurrence within the first year.